Ladies and gentlemen, friends, family, good morning, good morning, good morning, good morning to you. Good morning, good morning, good morning. And welcome to this Wednesday morning of the 5th Global Symposium on Health Systems Research. We had a wonderful welcome opening plenary yesterday and a very warm reception, and I'm delighted to welcome you to this morning. I hope you're as excited as I am. And I hope that you've had your breakfast. I hope that you're fortified because we have a really excellent session for you today. My name is Kwamie. I'm a researcher from Ghana and a member of the board of Health Systems Global. And I'm absolutely graced to be your MC this morning. So why don't you turn to your neighbor and say to that person, community health systems. I'm in charge, and I've said, turn to your neighbor and tell that person, community health systems. You can give them a little push if they don't look too important, and just give them a shake and shout, community health systems. Good. I just want to make sure you're in the hall with me this morning. So, community health systems, 3 words that on their own are important, powerful, and self-encompassing. But what happens when we bring those 3 words together in all of their dynamism and multiplicity? What becomes of notions of governance and leadership, of partnership, of equity and performance, and from whose perspective? So this is some of the terrain that we want to explore this morning. But before we get into the meat of what we're going to discuss, we want to know what you think. And to do that, we're going to use the Symposium app, the HSR2018 app. So at this point, I would like to ask you to reach down into your bags or your pockets and pull out your phones. And you can go ahead and open the HSR2018 app. So you should see an icon that says polls and Q&A. You can click on that. And there should be a question. You should see a question. I've introduced myself briefly to you, so just by way of warming up, we want to know who else is in the room. We know that many of us wear many different hats, but as a start, we want to find out who is in the room and how do you professionally identify yourself by your main activity. So do you see the question there? It is asking you to identify yourself. Are you a advocate, activist, or communicator? Are you a frontline worker? Are you a manager? Are you a policymaker? Or are you a funder? Or are you a researcher? So I see that the numbers are coming in. Once you have found yourself, you can just give it a click and press send, and we'll see who we are this morning. So I've got 10 votes. We have, the numbers are moving. I've got 36% researchers, equal amount of communicators and advocates, 18% policymakers, no frontline workers, no funders. I know that's not true because there's a session later on this week. So keep clicking, and let's find ourselves. Okay, policymakers have dropped by 15%. Still no frontline workers, still no funders. I know that's not true because we have a session later on this week. 15 votes, so the numbers are slowing down a little bit. Let's see if we have a few more people voting, and then we'll close this in just a moment. The app is not working. Okay, thank you for letting me know. So, because we are a resilient and responsive system, we're just going to adapt and move on. And we hope that we're working on it, and we hope that by the next plenary, the app will be up and running. Wonderful. So now, we wanted to conjure an image of what a community health system can look like. But rather than having me describe it to you in many words, we thought it would be better to show you one such health system and give you the voices from that community. So we're delighted this morning to be able to share a short film, which is one of an excellent crop of the multimedia stream submissions we received this year. And I'm delighted to also say that the multimedia submissions have been integrated into the panel sessions, so you'll be able to watch some of them as part of the regular sessions. And also, I would like to thank Anjali Rawat, who is the creator of the film that we're about to watch, for being amenable to edit a special version for this plenary. So I am happy to introduce and present to you the short film called Now We Are Free.
There was nothing. Nothing here in South Africa, nothing. No medication, nothing. We've been told that it's a disease that is killing people. You're going to die. We don't know if you're going to get treatment anytime soon. So I was like waiting for death and wishing for the best. Yes, there was challenges because the treatment site was far from us. So most of the time, most of our people don't have money to use for a taxi. They're not working, they don't have food, they sit for a long time at the clinics. It's not easy.
Over the last 5 years or so, particularly with the South African rollout, it hasn't been seen as part of a package of care you can access. There's this horrendous cartoon, I don't know if you've seen it, of the previous model. You know, you start with your local clinic, then you go to that clinic, then you go to the next clinic, then you go to this one. You get into the system through primary healthcare, but then you get referred to the special ARV services. That was saying that HIV care, ARVs, is provided by some parallel health system.
Imagine if you have got your HIV positive, you are also hypertensive for diabetes, you know. If you get in many different centers, you know, you should be regarded as one individual. In fact, patients regard themselves as that. They don't regard themselves as many different people, and it does frustrate them if you treat them differently. You say, look, I'm here to treat only your HIV/AIDS. You'll go to the next hospital or the next clinic, get into a taxi. That's why they treat hypertension. Then, you know, I mean, it doesn't work with people. We want to integrate all those services into one. We want to make them one thing, and all of them are chronic care.
That's the purpose of primary health care. I mean, if you remember the Alma-Ata Declaration, primary health care just didn't mean building a clinic.
Right.
Dishing out medicine, of course not. It meant social involvement, community engagement, looking at those social determinants. Talking about plus. So
They were our patients. They came here when they were sick for minor ailments, for chronic treatment. They used to come here.
Yeah.
It's just now he'll come for hypertension treatment and for ARV.
I think what I've been doing, I think I have to keep doing it to encourage other people to never give up.
Thank you again, Anjali, for that beautiful depiction of what a community health system can be. Now, the film, I hope, has dropped some seeds. It raised some issues about primary health care, about the people at the center of the health systems, and about proximity, place, geography, and what those all mean. And I know that our panel will revisit some of these items in their discussion. So ladies and gentlemen, now I have the distinct privilege of introducing our keynote speaker for this morning. Deputy Director General for Programs at the World Health Organization in Geneva, Switzerland, Dr. Soumya Swaminathan. A pediatrician by training and a globally recognized researcher on tuberculosis and HIV, Dr. Swaminathan has over 30 years of experience in clinical care and research, and has worked throughout her career to translate research into impactful programs. Most recently, Dr. Swaminathan was Secretary of the Department of Health Research and Director General of the Indian Council of Medical Research. Dr. Swaminathan has sat on many WHO and global advisory bodies and committees, including the WHO expert panel to review the global strategy and plan of action on public health, innovation, and intellectual property, and as co-chair of the Lancet Commission on Tuberculosis. Dr. Swaminathan has published more than 250 peer-reviewed publications and book chapters. And this morning will be speaking to us on health systems research towards the SDGs. Dr. Swaminathan, I invite you to the podium.
Good morning, ladies and gentlemen, and it's a great pleasure indeed and a privilege to be here amongst fellow researchers and talk to you this morning. And I really appreciated the introductory comments and the video that we all just saw. So I'm happy to be here, not just as a Deputy DG of WHO, because WHO actually organized the first two symposia, global symposia on health systems research. And it's wonderful to witness the momentum around these events, but also from my own perspective of being a researcher and having evolved from somebody who was very much into pure clinical research and clinical trials into a person who really believes in health systems research and the impact that it can have on country programs. It's also very fitting, I think, that we have this conference this year in Liverpool in the UK, where 70 years ago we had the beginnings of the NHS was established, and which has today become a sort of an example, a trailblazer for the universal health coverage principles that so many countries are now pursuing. The UK also has a long track record of funding health systems research, both locally and globally, particularly through the Department of International Development, DFID, and we are grateful for their support in this field. We're also very pleased to see that the National Institute for Health Research, which is an organization with a strong history of funding high-quality research to support the NHS and the nation's health and social care system, is now broadening its scope of activity to the global arena. And I hope that all participants here would engage in the consultation process being led by the NIHR as it explores opportunities to collaborate in collaborative research to improve access, quality, and equity of health systems globally. I have worked for a long time myself in the field of tuberculosis, and I see other faces here who are also TB researchers whom I've known for a long time. But it's a very good case study of a disease where the program itself cannot work very well unless you have a strong health system supporting it. Whether it's availability of diagnostics, we saw in the video also just now that you could have the drugs available in the country, but if they're not at the right place at the right time and being able to be accessed by the people in need, you're not going to attain the aim of being able to treat as many people as possible, whether it's HIV or whether it's TB. And that's where research on implementation and effectiveness really can play a big role. And this is what I think that more and more policymakers are beginning to understand, but it does need to really become very much part of policymaking in health systems. In addition to the health systems themselves or itself, we obviously have factors, the social determinants of disease, whether it's nutrition, housing, water, and sanitation, that all play very important roles in disease risk determinants and dynamics, whether it's tuberculosis or a host of other diseases. And this is where collaboration across multiple sectors is important, and this is very much part of the SDG agenda, where you could consider SDG 3 almost as a docking station for all the other, or most of the other SDGs really, which most of them would have an impact on the health of populations. So multi-sectoral action is important. And again, health systems and policy research can really help because of the transdisciplinary nature. It can evaluate innovations in multi-sectoral collaboration and analyze how these innovations can be scaled up. And we have approaches like participatory action research and embedded research, which really teach us how to work across a range of actors beyond the health sector to foster the action that is needed. And this is something that WHO is now emphasizing a lot in our new strategic program of work, the 5-year program of work. We have the 3 billion strategic priorities of universal health coverage for 1 billion more people, 1 billion more people protected from health emergencies, and 1 billion more people living healthier lives. And the 3rd billion, the wellness billion, really can only be achieved if there's progress in other sectors, in the other SDGs, which contribute to health. The other important aspect of health systems, obviously, is removing financial barriers that prevent people from accessing better health. TB, for example, is a disease of the poor. And this reminds me of what Mahatma Gandhi once said. He said, whenever you're in doubt, or when you think the self becomes too important, apply the following test. Recall the face of the poorest and the weakest person that you may have seen, and ask yourself if the step that you contemplate is going to be of any use to them. And will he or she gain anything by that? Will it restore him or her to better control over their own life and destiny? And then you will find your doubts melt away. This is an excellent guide to priority setting. In health systems, too, we must keep asking the question, how is what we are going to do going to benefit the people most in need? And applying the equity lens, I think, is the only way in which we can make progress towards the SDG goals. Sometimes it involves asking difficult questions and also bringing difficult issues to the table. There are different reasons for discrimination and vulnerability in different settings. In some countries, it may be migrants. In other countries, it's more caste-based. In other countries, it's based on your sexual preferences. And these are sometimes very difficult to discuss openly because of the political or legal situation in that country. But as health systems researchers, these are exactly the kind of issues that need to be laid on the table. So policy analysis, gender and equity analysis, and philosophy and ethics are all important guides for us. Health policy and systems research has been recognized as a science that supports universal health coverage, but also has the methods and tools to answer many of the questions that are now being asked in the context of these SDGs. This field is going to become increasingly important as we move towards these global goals. Some of you may know that the WHO was requested by the heads of 3 countries, Germany, Norway, and Ghana, to develop what's called a SDG action plan, or a roadmap. And what it is it's really based around the principles of accountability, of joint action, and of avoiding duplication and improving efficiencies, and calls upon all multilateral, bilateral partners and countries to really align themselves towards the shared goals that we have. We've also identified about 7 accelerators that will help us to move towards the SDG goals more rapidly. And one of them is research, innovation, and data. some analysis that's been done by the Alliance for Health Policy and Systems Research has shown that the number of publications in this area has gone up quite significantly. In fact, an increase of about almost 400% in the last 15 years. And we've also seen gradually increasing funding for health policy and systems research, and it's estimated to be in the tune of about $400 million a year. But still, 94% of this funding comes from about 10 donors. And compared to biomedical research, this is a very, very small amount that's being spent. For example, the annual budget of the National Institutes of Health in the US is over $30 billion US. So we definitely need to accelerate support for the generation of meaningful and relevant health policy and systems research. And in fact, we should thank all the funders that are present in this meeting for their unwavering support to this field. But of course, research can never be an end in itself. Neither can health systems research, should not be, in fact, should not be an end in itself. A publication in a journal is not what we should be satisfied with. Unfortunately, many of us who start off as academics, that is the goal and the end point, especially when you're a young researcher. You're in a hurry to get more publications. But as you go through your professional life, you realize that it's the impact you have on policies, on health systems, and on people's health that really counts for much more satisfaction. So it's not about 200 publications, but if one publication of yours could change the way in which ARV is being delivered, for example, and millions more people start benefiting, then I would say that that's much more satisfying for yourself. And for research to be used, it's important that the decision makers are involved right from the beginning, the policy makers. So very often we have two groups of people, the ones who are driving policy and implementing the programs, and the other group of researchers. And very often you find that there's really no connection or crosstalk between these two groups. And when the researchers finish their research and go to the policymakers with the findings, they say, well, this wasn't the question. Our problem was completely different. And if you'd asked us at the beginning, we would have told you what our problem is. So I think this is where involving the policymakers right from the beginning in developing the research question and being involved as far as possible in the research is likely to lead to much more rapid uptake of results. So we really need to shift the way in which we think about research and conduct research. The first, I would say, is to have much more interdisciplinary research. When I was in medical school, I wasn't given any classes in social science, never had any exposure to social or behavioral research. It's only much later I realized the value of having colleagues in the team who were social scientists and who could ask the right, because without behavioral research, it's unlikely we'll ever make big impacts in public health. Now, this health systems research actually gives you the tools, and by its very nature, it's interdisciplinary and multidisciplinary, and we need to be really strengthening that capacity and making sure that that fundamental principle remains very, very strong. It doesn't mean that basic research isn't important. It has its own place, but I think here we're talking about more delivery, access, and implementation kind of research. I'm sure I'm preaching to the converted here because all of you believe in the same principles that I'm talking about, but you will also recognize that in your own career paths, you might have had many, many obstacles and difficulties before arriving at a situation where you're able to really have an interdisciplinary team. The second radical change that we need to see is really the global skew in research, where the needs are the greatest in the global south or in the developing areas, but the concentration of researchers is in the global north. And I know that, again, in this community, there are lots of partnerships and collaborations, but we need to put the countries in the driving seat. So if there's research going on in Kenya or Tanzania or Ghana, it's the people in that country, in the institutions in those countries, who should be in the lead, who should be asking the question, and who should be driving the research. Of course, with collaboration globally is always good. And therefore, the funders of this kind of research really need to make sure and encourage this approach. And WHO is very much now in its again, I talked about our strategic plan and our transformation process. One of the key underlying principles is having countries, impact in countries and putting countries first. We will be strengthening our country presence. The WHO country offices will be strengthened, and the headquarters and regional offices will do everything possible to support the country offices, including in the area of research, in working with the ministries of health, with the institutions in the country, to build capacity, to support individuals there to really carry out high-quality research. And so I invite all of you, both people from institutions in the global north and the south, but also the research funders, to work with us on this initiative and to really think about innovative ways in which we can accelerate the number of researchers in the countries where the maximum number of problems need to be solved. And I'm very happy that I'll be meeting some policymakers later today to discuss with them how they would like to see this area emerge in their own countries. And the third radical change that we need to see is to develop a culture of research and learning in country health systems. Unless policymakers and program managers really appreciate the value of research, of findings, of data and analysis, feeding back into their own programs and helping to improve them, it's very unlikely that we'll see a big upscale in this. So we really need to see this as an investment and strategize how we will promote and use the research that matters for the health systems. And policymakers, of course, are usually tied up with their day-to-day priorities and setting, every day there's an emergency or a problem in most of the health systems. But they need to take a step back, really, and see how to integrate research. And WHO is ready to work with all of you here to do the research that will be needed to achieve universal health coverage. So I'm delighted to see this vibrant and energized health systems community here today. The field of health policy and systems research has emerged over the last 30 years, and I'm proud that WHO, through hosting the Alliance for Health Policy and Systems Research, has been a formative part of it. I'm also happy to see the emergence of Health Systems Global, which is a fantastic membership organization, and it's been really involved in growing and promoting this field. So my final message for this community here today is keep collaborating, keep experimenting, and keep developing the science, while bearing in mind that producing health goes beyond the health sector. WHO remains very supportive of this endeavor in this field, and as well as of this series of symposia. And I look forward to interacting with many of you later on today to get your views on how we can do even better to support this really important field. I wish you all the very best, and I'd like to thank the organizers for this wonderful opportunity to speak to you all this morning. Thank you.
Dr. Swaminathan, thank you very much for your eloquent address and referencing Gandhi, whose notion of the restoration to destiny really gets to the heart at what so much of our work is about. So you raise the issue of difficult questions and difficult issues, how they get tangled in the politics and the legalities and the ethics of much of our countries, and how health policy and systems research can be increasingly important to addressing and raising those questions, and especially how research systems can be learning systems and not research for their own sake. So thank you very much. Now, I'd like to introduce our moderator and our panelists for this morning's discussion. So I'll introduce them and then invite them to the stage. Our moderator this morning is in the person of Kumanan Rasanathan, who is based in Phnom Penh in Cambodia and is also a board member of Health Systems Global. He will be joined this morning by our esteemed and diverse panel, Amuda Baba from the Democratic Republic of the Congo, who is director of the Pan-African Institute of Community Health in Aru. Ariel Frisancho, who is the country director of the Catholic Medical Mission Board in Lima, in Peru. Manmeet Kaur, who is the founder of City Health Works in Harlem, in New York, in the United States. Stefan Peterson, who is the Chief of Health at UNICEF, also in New York. And Helen Schneider, who is professor at the University of the Western Cape, School of Public Health in Cape Town, South Africa. Kumanan, I turn over to you and your panelists. Thank you very much.
Thank you, Aku. Good morning, buenos dias, bonjour, vanakkam, kia ora, chumbripsur, and greetings in all the languages of the 140 countries and thousands of communities that are represented here today as we gather in Liverpool in our community of Health Systems Global. A community is a simple idea. It's a group of people who share a place or a common identity or characteristic, but it's often challenging in practice. The Declaration of Alma-Ata said that healthcare needs to be delivered with the maximum participation in the organization, planning, operation, and control of healthcare by communities. The Declaration of Alma-Ata says a lot about communities. It mentions community 14 times in a text of 1,118 words. But even here, at the start, which has inspired so many of our efforts to place communities at the center of health systems, we see the tensions. The Declaration refers to the whole world community. It counterparts community with nation, with families, and it distinguishes community health workers with physicians, with nurses, and auxiliary health workers. So even there, we see these tensions and the challenges that we in health systems have had in tackling the tensions and the diversities, the dynamisms of communities. We look at us as a community and we know how much we disagree. We disagree about whether last night's plenary should have had more or less talk or more or less music. We disagree about who should be on the stage and who shouldn't be on the stage. We have hierarchies of power within our community. Communities are fundamental to life, but they're messy, they disagree, and people belong to multiple communities. And yet too often in health systems, we talk, as we see in the Declaration of Alma-Ata, about the community single. The Declaration in those 14 instances only talks about communities plural twice. So that is the history we reflect on. And today, we still say in our rhetoric, without community health systems, we won't realize the right to health, we won't get towards health for all. And yet, beyond that rhetoric, we still pay scant attention and prioritization and respect for those principles we hold dear in the Declaration of Alma-Ata. So we're very fortunate today to have a very diverse panel of people who are passionate about community health systems, working from conflict settings in the Democratic Republic of the Congo, to neighborhoods in one of the richest cities of the world in New York, to at the global level, thinking what a global organization can do. And we look forward to a very interesting, diverse, and perhaps sometimes conflicting discussion on community health systems and how do we place them at the heart of service delivery. So the first question I'm going to ask, so that we get more of a sense of where our panelists are working and why they're passionate about community health systems, is just to ask, why do you feel community health systems is essential in your work and in your context? And I'm going to ask Amuda for you to start.
Thank you very much, Kumanan, and thanks for everyone for being here. I'd like, first of all, to set the context to describe the scene, and Kumanan put it very, very well. I'm really focused on conflict-affected settings and also settings of fragility. Why is that? Because, yes, we are all heading towards leaving no one behind, but we are also running a high risk of leaving fragile, and conflict-affected states behind, looking at all health indicators really going on. And not only the context of fragility, not only the context of conflict, but also there is another idea on rurality. In most cases, rural settings are really facing other challenges, and also adding to conflict settings. If you add the challenges on rurality, where they face serious issues on shortages of qualified health workers, then that's another problem. And that's why we mostly found, in most cases, you've got community health workers being really the key, really the focus of the people, because they are made of the community, because they make the community voice heard, they make the community ideas or the community's focus have place. So the focus on CHWs is really important, as well as some community-based organizations which really intervenes in terms of supporting community, in terms of making community's voice being heard. And we are going through some serious conflict within the northeastern DR Congo, where we've got more than 100,000 people living in IDP camps. And even in those IDP camps, there are some people who are still just relying on their community health workers, still looking for the community health workers to see what they can do to help them through what they were doing. Yes, it is very important to have a community health systems, which is community-guided systems, which will make the priority being described by the community.
Thanks, Amuda, for just reminding us that in so many settings there's no tension because communities are the health system. Mm. If I can move on then to Helen, perhaps in your context, a long-time researcher on why you feel community health systems are so essential.
Morning, everyone, and thanks, Kumanan. I think the evidence base for action and intervention in the community health system is very clear. That it increases access to care. It can provide an important safety net for vulnerable households and individuals. And it can also be a site of mobilization, collective action around the social determinants of health. It can be a space, a sphere that can advance multi-sectoral action, the Sustainable Development Goals. And in fact, that evidence base has been available for a long time. I remember the 30th anniversary of the Alma-Ata Declaration, the World Health Report of 2008, was already talking about how countries that had made the most progress towards improved health outcomes had invested heavily in community-based systems. And subsequently, the Good Health at Low Cost initiative also pointed to that as a very important sphere of action. So I think from a research point of view, it's absolutely imperative that we do engage with this as an idea. And particularly in its relationship now to UHC and how those ideas connect. I think we do have a problem of under-conceptualization and under-theorization of what is a community health system. There's been a lot of work on communities as sites of delivery. There's work on social accountability, community health systems as sources of accountability. But how we bring all these together, how we think about it. I mean, there has been quite significant work emerging in the last few years in a number of centers across research institutions and countries that are trying to characterize what this is. But I think from a research point of view, there's a lot of work to be done in this area.
Thanks, Helen. So we have the evidence, and we say it's important, but we still struggle with this tension between community as place and community as power and social relations. Ariel, to you and to your work in Peru.
Thank you. Good morning with everybody. I think that there's increasing evidence along all the world on the contribution on a system that engages better with the community. working with community health workers. For example, in Peru, in CMMB Peru, we have decreased anemia, we have decreased chronic malnutrition in a very sound way in 2 settings of Peru, but our experience is similar to others in Peru, like Prisma, like Future Generations, etc. So there's a value on working with community health systems. They increase, they extend the services, they could increase access and demand. They address the social determinants of health in a wider understanding than the one that usually we do. And they also address the culture of the people, because in Peru, as in many Latin American countries, we have multicultural societies, and sometimes culture is a determinant for demand, access, etc. However, I would like to analyze this under the R word, rights to the people. No? If we take the dimensions of rights, they could contribute with availability together with the state, pinpointing the important things that are gaps in the system. They contribute definitely with accessibility, in improving demand, improving access, having a better understanding on what happens in the facilities, in acceptability if they are heard by the system, and in quality. However, I will add a 4A, accountability. There's no rights without the 4A, and I think there's much to do there. Community health systems need to have governance and accountability at the center of their development process. Because, and I'm going to talk more about this later, we need all to learn to listen. And we are not necessarily listening the community.
Yes, yesterday in a session, we heard someone say that the challenge of health systems is often we want to tell, but we don't cultivate enough of our listening ear to communities. Rather, we just want to tell communities what to do. Manmeet, perhaps in your setting, in New York, why are community health systems so important?
Sure. So thank you again for having me here on this panel and at the conference. To contextualize the work that my team and I are doing with community health in New York, I should share that I spent about 5 years working in South Africa, India, and then sub-Saharan Africa on community health and workforce development systems, and came back home to New York to with the interest of showing that there is value to the US healthcare system in investing in a workforce that is neighborhood-based, that is non-clinical, with the right systems and support and structure around their role and involvement in a delivery of care that enhances what happens with primary care. And in our context, the need for this in a place like New York City, which has an abundance of riches of many sorts, but in terms of medical care, we started in East Harlem, which has, within 2 zip codes, 2 of world-class academic medical health centers, dozens of clinics. So it's not that there isn't medical care, but if you look at health outcomes, mortality rates are 10 years. Mortality rate is 10 years lower in East Harlem than a few blocks down in the Upper East Side. So the US has a big problem around inequity and how our resources are used to achieve health versus just responding to crises. And so I've been working to show that if you meaningfully involve a community health worker, in our context, we're focused on chronic illnesses, that they can demonstrate very strong impact, as we know from the research, but as we're trying to show through practice, in clinical health outcomes, in self-efficacy and self-knowledge, and then third, in terms of cost. And so our ability to sustain this is our ability to show to the health system that we're improving these outcomes, both on the health as well as cost savings, around which there's a huge delta in the US, where 18% of our GDP is on healthcare. We spend $10,000 per capita per year in healthcare, and our outcomes don't reflect at a population level what they should be, given our spend.
Yeah, I mean, thanks, Manmeet. It's so important to have you here. I think people often think of community health systems or as some stopgap measure that whilst people pass on to a sort of more advanced so-called health system, and yet to show your work and the importance of community health systems in a city where most people just bypass primary care, right? So Stefan, why, and the global system's been talking about community for a long time, with often not so much progress. So why is it so essential for your work, this concept of community health system?
Well, this will be a mix of UNICEF and personal perspectives, but 5 things I want to say. Don't get scared. Now, I learned in Uganda from my mentor, Professor Maswa, that health is made at home and hospitals are for repairs. And that's sort of something that has really stuck with me. So it's the household production of health and how we support that. And the closest we can get is the community health system. I'm already on my second point. Which should not be seen as a last mile health system. In fact, it's a first mile health system. It's the first mile from your door, isn't it? And most of us stay within a mile of our door. And it offers geographic, financial, but also social access, to come back to Soumya's point about the equity lens before. So I think that's very important. Thirdly, there's much talk about primary care now, and there's talk about primary health care. And sometimes we confuse those concepts now. And I think that the community and the front line of primary health care can actually realize the 3 legs of the primary health care stool. One leg being the service provision, preventive, promotive, curative, which I'd like to dub primary care. But then we also have the multi-sectoral piece. You've spoken about the social determinants, but it's also things like water, food, breastfeeding, all of those good things that really need to be there to produce health. And thirdly, as you alluded to, Ariel, here, the community engagement as the 3rd leg of that stool, and community empowerment. So that's where I think the hope is for the front line of the healthcare system. Fourthly, if you actually try to look at the evidence, as you said, Helen, it's very effective. We can take care of 3/4 of the preventable maternal child health mortality in low and lower middle income countries at that level, and it's good return on money, 10-1. And fifthly, because it's exciting, this is where the innovation is. It's social, it's technological, and this is sort of really the cutting edge of public health, I'd say. So that's why.
Thanks, Stefan. Of course, the audience is disappointed you didn't sing that. But,
okay, it will come.
So what we've heard already, though, is all the reasons that we all believe about why the role of communities is so important, as enshrined in the Declaration of Alma-Ata, that in some settings, the communities are the health system, that there is sort of evidence on what communities can contribute, that they're required at all settings, regardless of resource level, and that they're fundamental to some of the targets that the global setting has set, for example, in Sustainable Development Goals. And for all that there are these wonderful experiences from the 70s, from the 80s, from today, including on the stage, we still see this challenge of the lack of resourcing, often the instrumentalization of the community level, not paying due heedance to the issues of power, to rights, to governance. And so why do we sort of see this paradox? It's so important, makes sense, it works, and yet we often don't prioritize communities in our discussions on health systems. I wonder, Helen, if you want to reflect a bit more on why we haven't seen the progress we might have hoped for in the last 40 years.
So I'd like to pick up on what Ariel and Manmeet were talking about, and Amuda to some extent as well, which the sort of the micro practices, the everyday practices of governance accountability at the coalface of the system, and how the relationships work between players in the community health system and the formal health system, and where vertical hierarchical modes of governance have to meet more horizontal collaborative modes where it's essentially about trust and reciprocity and collaboration between people who otherwise don't have to work together. And I think that is an incredibly difficult thing to achieve in a health system. The tendency is often for primary healthcare, formal primary healthcare players and professionals to want to incorporate the CHS and players in the community health system as subservient players meeting their needs, often within health facilities. But I think that there is a bigger challenge in that the community health system there hasn't been enough investment in it. I mean, there's a lot of talk about it, but very little serious investment and attention. And it's often seen as a space where problems at other levels of the system will get resolved at that level, which is very problematic because it sets up a whole lot of expectations that just can't be met. And if we had CHWs or members of the community health system sitting on the panel, they would reflect, I think, a very different narrative to the very idealized, romantic ideas and a much more troubled representation of what actually goes down there, which doesn't mean that doesn't have huge potential and you know, that there is capability, but that one has to not see it as simple and easy and cheap. And that's the mistake of an earlier generation, particularly of national community health worker programs in the immediate post-Alma-Ata period. And we're sort of having a swing back to seeing the sphere as a sphere of intervention, but we need to pay more attention to the lessons of history, I think, in this.
Great, and you sort of make reference to this fact that often there's this challenge of integrating communities into the health system rather than engaging on equal terms and overcoming that power asymmetry. People might say, well, do you really have frontline community people on this panel? Do we also have a similar problem of integrating those perspectives into the formats and the sort of forms of our sort of symposia? But there's also sort of other issues around that and doing that. Like there are some tremendous gender issues when we talk about communities. Would you like to sort of reflect on that?
Yeah, so it's one of the big challenges is the assumption that people in community health systems have a lot of spare time and are able and willing to volunteer on a mass scale for large amounts of their time, in particular women, okay? So it's a very gendered response often. That is one element that undermines its sustainability, I think, is an expectation of free labor from particularly women, I think.
Right, which is sort of seen throughout the health system. Really,
yeah.
I'm moving to Ariel. Do you want to reflect a bit more on the challenges? You started to talk about some of these issues around power in Peru, which maybe explain why we've struggled with moving forward.
How much time do I have? I will talk about five points, try to make it quick. Challenges. First, the understanding of community health systems by those who take decisions. After Alma-Ata, there was a wide spread of training for community health workers, many times understood community health workers as an extension, a helper to implement very good intended plans, but they never participated on the design of those plans, no? And still it happens. So political will and understanding on what is entailed on promoting community health system is paramount. Second, technology, because it's not that I decide to be more participatory with the community and then I know everything. We need some specific participatory technologies. We need to work with our teams in the health systems so they could also understand that. And part of that technology needs to make a change in the attitude of the providers, no? So we need to learn to listen, and we need to know how to promote that expression from the community in a more fair way. And some very bad listeners are medical doctors. Believe it or not, there are some countries, maybe not yours, where medical doctors are stubborn, they reject critics, and they get angry with them. No? And they will never accept lay people tell them how to do their work. There are some countries like that. So it's a very big problem for us sometimes to make medical doctors understand that another voice, just like in the video we saw, no? Looking the system from the point of view of the people that are going to the system and what they suffer in the different steps, etc., will help them to improve their work and maybe make it more efficient. No? Third, power. Part of that problem challenges is the power relations. We are facing unequal power relations between community people, community leaders, and those who know the information, those who have the decisions on their side and don't want to give the decision-making or be influenced by the decision-making of the community. Talking about rights, another way of seeing it is, as Helen said, equity. Equity on protection and prevention. Equity on health care with no discrimination, etc. Equity on knowledge and power distribution. That's a dimension of health rights that is needed if we want really to promote changes. Fourth, I will talk about community because it's not, as you said, an issue of good people and bad people, good community, bad government or providers. No? Communities are heterogeneous. They also have their own conflict of interests. Sometimes social action is driven by political partisan positions. And then government feels more challenged to accept community participation. Whatever the weather, we need to work. Nobody said this is easy. Nobody said this is going to be fast. No? And when we talk about technology, we need time, because processes are time-consuming, resources. Somebody has told the governments that working on community participation, as you say, is a matter of donors or some volunteer work. No, we need resources, we need technology, no? And we need organizational arrangement for that. And last, donors. I'm very happy of the Millennium Development Goals, but a consequence of the Millennium Development Goals was that donors didn't pay more attention, not more, to finance processes that are complex on themselves, no? Because we are working not only for having strict results that are A plus B equals C. No? We need to be aware that not, a single size doesn't fit all the needs. We need to be aware that there's the diversity and there's going to be different results, and we need to learn from those different results. And then we were just running behind metrics, and donors said us, okay, how many maternal death this is going to reduce? And we cannot make that math, no? And researchers, I think, maybe this is my impression, but there are some processes of, for example, empowerment and change that could only be analyzed through qualitative research. And somehow I have the feeling, at least in countries of Latin America, that qualitative research is seen like a lesser level of research. I mean rigorous qualitative research. We need to put it on the center as well of this discussion, because there are processes of change that could only be analyzed in terms of qualitative research. And we're talking about real change, from a woman that didn't participate out of their houses to a woman that is standing in front of the authorities and trying to bring the voice of her community to a decision-making process.
Great. So a number of challenges, and we should move on to solutions in a moment. But before we do, a lot of the discussions here do have implications around the support that the global system provides in a world where, even more so than ever, domestic resources are what matter. Do you think, Stefan, the global system has reflected enough on its shortcomings or where it could have done better and the challenges around taking this agenda forward?
I think if I look at historically, trying to reconstruct the last enthusiasm, I think it was not long after Alma-Ata that we introduced selective primary health care, which was one nail in the coffin, if you will. And then we proceeded as a global community to structural adjustment, which is the antithesis of the human capital approach that we're talking about now. And then we proceeded to, I think, the decade of vertical disease approaches, or is it 2 decades now? So I think that's contributed to why we are in the position we are in now. Then we've underfunded health systems in general, I think, and then when we've been unhappy about the outcome, we said, let's bypass the formal healthcare sector and let's go to the community and send out a volunteer in a torn t-shirt, and that's going to fix things. And on top of that, we've overloaded these volunteers. We did a program review in one country and found that the community health worker had 350 tasks to do, which obviously was not really feasible even on a 24/7 basis. Meanwhile, I think we've rediscovered in bits and pieces the role of this. We've already alluded to vertical programs sending out their own community agents one by one. And one of my master's students, when I was a professor at Makerere, I'm proudly wearing the tie here, actually took, for the master's project, looked in a particular district who was volunteering, and found it was typically the same person who was volunteering for all the various disease programs, thinking that, well, if Amuda gave me a t-shirt, maybe Kumanan will give me gumboots, but maybe Helen finally will pay me. So you had the same people undergoing all of those trainings, and we never quite put it together. Meanwhile, I think many NGOs did nice community health workers schemes, but they became pilots, if you will. Maybe large pilots, but never on a grand scale. And I think as we take stock now, we must really say that it's no longer the community health worker situation we're in. We have a diverse set of frontline providers, many of whom work in drug shops in private sector now, that we need to incorporate into this. And we can't exclude and make a difference to the nurse in the community health center from this community agent. So I'd like to refer to it as frontline health workers, and I think we must be much more humble in seeing the diversity now and not one size fits all.
Great. It seems, though, that, as you say, often when health systems do engage with communities, there is this desire to make it a program, or as you say, a pilot, as if you can abstract all of communities and their complexity into one part. And I suppose the question that we might raise as we go forward is that still in an era where, of course, mortality results matter, or in an era of performance-based financing and results-based budgeting, whether we have turned the corner to really invest in the processes, the mechanisms that are so central to taking this forward. So we've listed a lot of the challenges, but maybe if we can think about some of the solutions or what does work, and maybe turn to Amuda and Manmeet, who are working at the front line in community health systems. What do you feel is most important to take this agenda forward? What's working in the work that you do?
Thank you very much, Kumanan. And I would like to come on some issues which are raised and asking another question. Whose health system are we talking about? Because whatever the health system is, it might be a community health system or any other health system. I think the focus is still the community. So if the community is the focus, then they need to be taken seriously. As we know, the expected outcome of any health system is improved health condition of the community, of the population. So in that situation, I think it's very important just to consider the population very seriously and to have a setting of understanding really what the community needs. And it also depends on a kind of governance system you've been on. This depends on the history of the country or history of the settings. For instance, we are from a top-down approach where community needs to be taken, to be trained, to deal with some issues, to mention about their rights. So I think for what we see on the field, for what we really realize, that can still happen, but we need to have a very serious social empowerment activities. So when population is empowered, knowing their right, knowing the way they can address some issues, then it's really making change. Of course, it takes time, but we need to start from somewhere. In that context, it will not happen if we don't deal with social empowerment activities within the population, especially talking about the rural settings here and also about the fragile settings, which sometimes face many other issues related to the context they find themselves in. So I would like to focus on whose health system are we talking about? Population focused, population driven, but that population needs a social empowerment process so that they can deal what they intend to deal with.
Can I follow up on that, Amuda? You talk about the importance of social empowerment and social empowerment processes, and I think we'd all agree with that. Although empowerment isn't something you do to people, is it? I mean, empowerment is people seizing their power, often from others. There's contestation. And we often talk in health systems about empowering people as if they're slightly passive. So do you want to sort of expand on that? How do you work? So even with your work, there's sort of power differentials in your communities. So how do we support people to seize power, which is what empowerment is?
I think that it's, as I said, I put it in a special context, a context where people have been led by a top-down governance system. So it really takes time. It needs you to be there, to have sessions, to listen to people, especially having that courage of expressing their needs, of expressing their right, because they think they cannot express their right, there will be some other people dealing about their right. So it really takes through some social activities within community. For instance, we've got, where we operate, we've got a women's group. Women thought they could not be heard, but just calling a meeting where women could come and facilitate that process so that they can express what are maternal issues they are really facing in the areas and what can they do to deal with those issues. And I thought that was the first point, really the turning point of that empowerment. Of course, they cannot have it probably straight away. It needs to be taken through a facilitation process so that they really have it.
So creating the spaces and providing some of the resources for people to seize power.
Exactly.
Manmeet, in New York, in your work, what do you focus on, or what do you think we really need to emphasize in community health systems?
Sure. In terms of what we're seeing in terms of how we know if it's working or not, I can say from a data perspective and then a person perspective and then a clinician perspective examples where we're seeing that impact, particularly around creating enabling people to take greater control over their health. In terms of people, we had a partnership with a policy research institute called the Urban Institute in the US for a year. And what they looked at, they did two qualitative studies. One was interviewing our clients to see what do they think of health coaching and what were their perspectives. And the number one theme that came out of those interviews from our clients was, it was the first time I learned what to eat. And if you think about it, for people who have diet-related or pulmonary-related health issues, the majority of the interactions with with healthcare providers is, don't eat salt, don't eat, don't eat this, don't eat that. But that doesn't tell you what to eat or how to eat, especially for folks, many of whom are eating 6 green plantains a day because that's all they can afford, or they're eating only rice and meat once a week because that's what they can afford. So enabling somebody to do that under constraint requires a personalized engagement and opportunity to give them knowledge, give them skills, and then through that process, confidence to figure out how can they make it work, along with information on resources like food pantries and things like that. From a clinical perspective, we see really strong outcomes. I mean, to a degree that surprised me even in our work. For example, with patients who have diabetes, it takes a 0.5 reduction to get a drug on the market for diabetes, for your A1C or blood sugar reduction. Through our health coaching, which is just two people talking to each other over a couple of weeks to give them knowledge about what does this disease mean, how do I eat, what do these medications mean, what are side effects, et cetera, we see a 1.6 reduction after a year, and a 1.3 reduction after 3 months on average. So on clinical outcomes across a range of metrics, we're seeing huge outcomes. On the cost side, which is very important because our ability to sustain this beyond a pilot, beyond something that looks nice in one area, is showing to our industry we are meaningfully affecting costs. We saw a $600 per member per month drop in spending in our first look at the data at 10 weeks of just coaching. And so one of the doctors that we work with jokes, it's better than metformin with only good side effects. And essentially what it is just time, personalized time by someone who's very educated in this health coach role that we've created to help them understand what is this disease? What does it mean to my body? What does it mean day to day? What is it that I have to do on a quarterly basis? What assessments do I need to do on an annual basis? I loved that image in the video of South Africa early on in terms of these vertical approaches to ARV and treatment, because that's what we have in the U.S. You go to one type of doctor for your pulmonary health. You go to a different type of specialist at a different level for a different health condition, but there's nothing really unifying. And so the two big structural problems that we are addressing that are core to a lot of the research that this community has worked on globally for so many years are the self-management piece, the self-knowledge, this empowerment around how do I as a human being understand what to do day to day in my life with these conditions in my home and my own health and my family's health. But secondly, how do we address this issue of deep fragmentation or disorganization in terms of how healthcare, critical healthcare services are delivered? So in the US, even though we have an abundance of riches of availability of types of specialists and doctors and nurses and dentists and everything, we don't have a clarity around how do you make the experience continuous and continuous with support from somebody who's along with you in your journey, throughout, versus going to one place of care for one special need and just being repaired for that. To use your analogy, being repaired for that need and then jumping, being sent to a different specialist or a different office for some other purpose.
Great. It's sort of a reflection on, are we in health systems really prepared to invest in, as Stefan referred to, the co-creation of health? And that's as much about time and respect as it is about resources. One thing, and I'm very pleased, is that this discussion on community health systems hasn't just quickly become only a discussion on community health workers. Because over the last 40 years, often when we talk about communities, it's not about the organization, the planning, the operation and control of healthcare overall. It becomes a very focused discussion on community health workers. But I would like us to touch on community health workers because we have had so many important experiences. As you know, 20 years ago, this idea of community health workers as lackey versus liberator, as a servant or tool, or versus a means, a facilitator of social empowerment. And I wonder, given there is still a lot of discussion on the role of community or frontline health workers in health systems, maybe we could touch on that slightly. Amuda, you work a lot in training community health workers. Do you think we've changed our approach to reflect on some of the challenges, and where do you really want us to go in terms of what we need to ensure that frontline health workers can deliver their potential?
Thank you very much. I think the first thing to understand, it's not a one-size-fits-all. Again, it's contextual stuff and depends on how community health workers are really organized within different countries and within different settings. But I really think in most countries, they are really key actors, and the concept of voluntary interventions, I think, needs to be rethought. We need to rethink it, because as just Stefan mentioned about voluntary, you can end up having a CHW voluntary, but in very different programs, and which can, in a way, hinder the interventions. So I think they are really key actors, and talking about rural settings, as far as I'm concerned, in some areas, they are the frontline workers due to short shortage of some qualified health workers, they end up managing some community, what they call community sites, where they provide some basic health activities. And Stefan just said, you end up seeing someone having more than what is expected from them. And that's why putting those community health workers with what they do, of course, they are very important actors in improving health within especially rural settings. But I just describe them as street-level bureaucrats, the way Lipsky just put it, the way they do, and sometimes in a very difficult conditions, but they have their coping strategies, but also sometimes they just use their own logic to see how they can deal with difficult issues. So yes, they are very important actors, and I think we need probably to rethink on how to support them, on how to really integrate them within the health system, because for most of the population, they are the entry point within the health system. So they need to be seen in that way, how they can be supported in a way they are health workers. In English, I like it, it makes sense. They are community health workers. In French, it's different. They say relais communautaire. So they are just relay between the two. But they are workers, and workers deserve to be paid so that they can be productive and so that they can make the best of themselves. So I would think probably to sum it up, to rethink on their role and also to see how we can improve their regular support in terms of in-service training, in terms of supervision, but also in terms of salary.
Great. Ariel, from Peru and Latin America, such rich experiences with social activists and institutionalizing community health workers. What's being done differently, and are we going in the right direction?
Well, I think in many Latin American countries, there are now some guidelines to work with community health workers. Still, there's a problem on implementation. And this, again, has to deal with time-consuming, resources, and technology, and changing some attitudes. Having said that, some attitudes are also against more community participation because of corruption. Because sometimes community participation gives light to things that happen in places that the authorities doesn't have access to. And that's why there are many experiences in Latin America on social accountability efforts linked to other control organisms of the state, like ombudsman, etc. No? This is something that we need to explore more. I think we lack of a real serious analysis in the countries on what has worked and why, which are the principles. We need to see things about the selection, about the training. If you train in their language, if you train, being very aware of what are their concepts of life or health, how they are monitored, if they are going to be linked to another community instance, like community health committees, etc., that should support the work of community health workers, because we have said it's beyond community health workers. But what we have now in most of the countries is community health workers. Community health committees and other instances like this still need to overcome some of the challenges that we have mentioned about power relations, power dynamics, technology, skills from both sides to make a healthy relation. And then we need to be aware of some issues, the confusion, the tension between participation and tokenism, the tension between representation, real representation, no? The tension that exists between the concepts. No? Accountability is not an information meeting. It could begin with an information meeting. But accountability is around commitments and obligations for the people, information raised, analysis, if possible, made by an independent actor and with community participation, and redress. If there's no redress, there's no accountability. But sometimes we just allocate accountability as an information meeting. Universal health coverage is not only about financing. There are some countries in which universal health coverage is confused as universal health insurance. And that's important. No? Having everybody with a mechanism of financing of their health care is important. But we are missing geographical challenges. We are missing cultural issues. We are missing the same healthcare science development for a specific population, especially the most vulnerable. So we need to work on that. As was said before, we need to find a way of making research and action oriented to real people-centered systems. And I think this dialogue doesn't end here. There are many, many panels that I have seen in this, and I congratulate the conference for this, focusing on community health system. There are many panels. There's one on quality. Tomorrow there's one on the theory of change of social accountability on Friday. And let me please make an announcement. Next year, in October 15th to 18th, COPASA, the Community of Practitioners on Social Action and Accountability in Health, is implementing a global conference, a global symposium with the themes Leaving No One Behind, Strengthening Community-Centered Health Systems for Achieving Sustainable Development Goals. So it's like a twin of many of these discussions. This is in October 19 in India. I hope I will see some of you there. But we need to continue work on this. I think governance and accountability is paramount if we want to really have community health systems and not just another checklist of what we have done.
Thanks, Ariel. And following Anthony's sort of example yesterday, people are allowed to have their vested interests when they come up on panels. Maybe we should allow people to wear their logos of the things they're promoting, conferences, books.
I had one.
I think we'll move on to sort of finishing when thinking about research, because at the end of the day, this is a research symposium. But 2 points that you raised, of course, there's many sessions in the symposium on looking at community health systems and community health workers. And a couple yesterday thought about this issues of voluntarism and also the success relatively of committees with workers. I mean, the voluntarism issue, I think most of us would agree people should be paid for labor. At the same time, there are some contexts where people resist becoming agents of the state because they feel that undermines their functioning or their sort of identity in terms of working at the community level. So it is complicated. Helen, maybe first to you, because you have such a long history in health system research with communities. Ariel said, oh, well, do we have enough documentation of what works and what doesn't work? And yet, if you look, there's so much literature around this topic. So what have health systems researchers been doing well in terms of research, and where are we failing? What do we need to do better? What does this community need to do better?
So I think we know what interventions work, okay, what community health workers in particular are capable of. So I mean, Manmeet provides a very compelling account of just how powerful it can be. What we know much less about is how these become scaled up within health systems. We know much, we don't know enough about how to organize support systems, for example, at a primary healthcare and district level. And we don't know enough about how interventions in this space engage with the broader community health system. So community health workers, as in the narrowest and crudest sense, as distributors of a few commodities in a very vertical program, is very different to the kind of empowerment that people are talking about. What are the kind of policy and governance frameworks that prioritize that? And I think there's an important framing that's needed in policy. And we need to understand, and that research has to come from a country base. It has to have not a siloed vertical program. We need to start bringing all of these different cadres and interventions together. We need comprehensive perspectives on the community health system and think of it as an autonomous sphere rather than a subordinate sphere or simply an extension of the primary healthcare system. And how to think about that, I think, is quite important, and how researchers and policymakers engage in that, I think, is quite key. We need much more research on how to understand and characterize the community health system. What are its capabilities? How does one understand the capacity for collective action? How does one understand the social and political norms, how those work together, and how agents from the formal health system, such as CHWs, navigate and negotiate that system? And the enabling policy frameworks and support systems that really allow the sphere to actualize its potential rather than always being seen as a second-class citizen. Yeah.
Great, sort of a number of issues for us to consider further. Manmeet, yesterday you told me that coming to this conference, your team was a bit like, why are you doing this? Where are you going? You're going to a health systems research meeting. So when you go back or to this community, what can health systems researchers do for you to help your work?
It's a good question. I think that the biggest focus of my, thematic focus for me around health systems, and expansion of things at work is the expansion of things at work. I think there's a lot of wonderful research out there around interventions, and I think that the real hard work is around how do you take things at work and figure out how they fit within complex ecosystems of not just like the healthcare system and community, but also the other sectors that enrich and enliven and compose a neighborhood or a community. And then how do you make them spread? And so I pursued an MBA for my graduate school studies, and I took a long time to figure out which degree program would make sense. And I think now, a couple of years out, as I've been building this, we've gone through a proof of concept phase. We've been doing essentially testing, and we've taken evidence-based curriculums and methodologies from evidence and research and been working on how to make them make sense in a context of a neighborhood, now a second neighborhood. I think the biggest focus that I'm facing, which I think many of, probably practitioners or people in this room and researchers would be thinking about, is where else can we learn from in terms of what makes successful solutions, especially service operations that involve people, work at scale. And so I think that this community taking deeper analysis, continuing to look at analyses or supporting the creation of taking these pilots or studies and scaling them. I will be looking for those papers and continuing to help inform our own effort.
Well, there's literally thousands of people here this week you can talk to. So if anyone wants to help Manmeet, please go and see her at the end of this session. Okay. So we're going to move into a wrap-up in a minute. It's been the hour's gone quickly. But I wondered, Stefan, is there anything from your point of view, what do we need more from health systems research to realize the aspiration for the role of communities in health systems?
Yeah, definitely. I like to think of myself as a recovering academic. So it's very nice to give you guys advice now and request. But in all seriousness, it's a partnership to produce this knowledge. And in UNICEF, we like to say rights. But once you've said rights, you also need to think of the duty bearers, and then you're in Ariel's shop of accountability. So the whole area around social accountability, how to strengthen the demand side in this equation, whether you call it empowerment or not, is where I find ourselves fumbling. There are sort of nice boutique projects here and there. Maybe Kupasa can offer me more. I'll be at your conference. But how can we empower these frontline workers now to actually be agents and mediators for social accountability without necessarily becoming bad messengers and stand the risk of being shot as a bad messenger? So I'm sure there's innovation out there for how we can actually do this. What role can technology play? How does it interface with the face-to-face meetings to actually strengthen demand side for the empowerment and the social accountability? For scalable social accountability, I must say, because there's any number of small pilots out there as well. And my second challenge, very quickly, is to the policy researchers out there. I think there are 3 mega trends I see, or 3 big vehicles moving now. One is the UHC train. The other one is the SDG 3 roadmap. that Soumya related to, and then we have primary health care, which we're going to sing allegiance to in 2 weeks' time in Astana now. How can these three trains come together and actually deliver together as one? And please help us shape that and also write the history, and I hope it'll be a positive history, so that all of these come together, in my view, through primary health care and with a focus at the community level.
Although, Stefan, I thought the UN was already delivering together as one.
Totally.
Right. So to close up, and actually I set the timer so that it expired 5 minutes before we actually have another 5 minutes. So I wonder whether we'll just go through the panel and think, we've covered so many topics in this hour, and we do apologize our plans for the polling question, which is why we now have the 5 minutes. It didn't work, and again, some learnings around maximizing the participation of communities. But whether we'll just go across our 5 panelists, maybe a final word that you'd like to say, thinking about how to take forward and really place communities at the center of health systems. And maybe start with you, Manmeet.
Sure. I think that the framework that I came into this work with was the worker. My background was around workforce development, and I was very interested in the question of how do I make the business case for this type of community health worker. And 7 years later, I realized what I have actually spent my time on is figuring out we are serving people who have preventable chronic illnesses, and what is the care model that makes sense for enhancing existing care to enable them to be successful as people in managing that care, and that the worker is a part of a solution, but it really requires careful development of a system that can utilize that worker along with the primary care team, along with the use of tools like software, along with the use of clinical dedicated supervision, which is essential. And so I think of a reflection on this theme that I'm coming to is I'm realizing I thought I was solving for making the case for a workforce, but I realized what I was doing to make that case was solving for a gap in care for people, and that it's most important to figure out what is the solution for population, and how does that then translate back into meaningful, dignified design of workforces and systems of care.
Great, thanks, Manmeet. Ariel?
Yeah, I think that considering the community's perspectives and needs into decision-making processes could shift the last mile of service delivery to the first mile, as Jonathan Fox says, the first mile of a relation between citizens and the state. At the end of the day, we're talking about democracy, more democratic health systems. And for that, we need to learn to listen and not get confused. Empowerment for the people to make good intended plans where they don't participate, or empowerment for the people to question, to identify pitfalls of the systems, to opening the health system to vulnerable populations that are still not attended. So the question is there, the process is long, it's complex, but I think if we really want better health systems working for the people, we need to talk about governance and accountability.
Yeah, thank you. I'll be short. I think community health system is really one of the keys for UHC, provided we invest much more in social empowerment, especially for rural communities.
Helen?
Yeah, we need a lot more embedded country research in this area. We need to recognize that the community health system tends to express itself in very context-specific ways. So we might, while primary healthcare facilities, district hospital districts may resemble each other across the world, community health systems are always very, very context-bound. And the way they evolved are often, develop very unique identities and characteristics. So we need to avoid global blueprints. We need to avoid imposing one-size-fits-all solutions. I think that's quite crucial, and I think an embedded country research and the capacity for embedded country researchers to dialogue with others, I think in partnership, obviously, in collaborations across the globe, north, south, 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 I think will advance this agenda.
Stefan?
H figures in many of our acronyms, in UHC, in PHC, and even in the community H system. The H means health, and it doesn't mean healthcare. And that implies the community empowerment and the multisectorality. And I think that's my big challenge for us, to remember that the H means health and not healthcare, and actually keep reminding ourselves that even though we went to nursing or medical school, many of us, we need to think outside that clinical box. So can I summarize?
Sure.
Yes. Now, I think the importance in all of this is going to be from community. So it's a replay, I must say. But you know what UHC stands for? U is for universal, H is for health, C is for coverage, and that is UHC. Equity and power to survive and thrive. UHC is built from community and up. So that's my summary.
A global health conference isn't a global health conference without a Stefan Peterson song, right? So, a focus on individual agency and self-management, governance, empowerment, context and embedded research, nursery rhymes, health is more than healthcare. 5 or 6 keys to take forward our mission to place communities at the center of service delivery, to live up to that Alma-Ata promise that community participation must be maximized in the planning, in the organization, in the operation, and on the control of healthcare and health. I'm not going to try and sum up more than that. We've had a very rich discussion. Apologies for the lack of ability to engage with the audience, but thank you to my panelists. Let's hope that we don't have to do this again in another 10 years and reflect on Alma-Ata and say we didn't deliver. Many people are going on to Astana in a few weeks. Let's get primary health care right. Let's really live up to these promises we make as the health sector to place communities at the center. Thank you very much.
Kumanan, thank you very much for moderating such a stimulating panel, and thank you to the panelists once again. I know you want more, but I assure you that this is just the beginning of an ongoing discussion over the next few days through the poster sessions and the oral sessions and the hallway discussions and the tea and the lunch breaks. I encourage you to delve more into the issues that were raised here this morning, so as we move forward our thinking on what community health systems are. I see some people leaving. I'm going to ask you not to go. We're not finished quite yet. We've come to a very important session, an important moment in our community. So those of you who are leaving, I will beg your indulgence to please stay for what we're about to do next. So as every community has its values and its practices, here within Health Systems Global, we also have our values and practices. And one of those is to give honor to whom honor is due. And so I'm happy to invite to the stage 2 who are mightier than I to present the Society Awards. So if you would please join me in welcoming the Chair of the Alliance for Health Policy and Systems Research, David Peters, and the Chair of Health Systems Global, Asha George. Thank you very much.
Thank you, and I am delighted to be able to introduce and give honors to our awards that are presented from both the Alliance for Health Policy and Systems Research as well as Health Systems Global. We do not have an award for Best Song, but we can always consider that for next year. We do have an award. I get to present the first award for lifetime service to the field of health policy and systems research. And this is an award that comes from nominations from you, from the community, and then it's given to a panel from both the Society and the Alliance, and it's always been a very difficult choice. The Lifetime Service Award is really based on 3 criteria: original research, promotion of utilization of research, or educational leadership. And I have to say that when you hear this year's winner, you will note that she is really a winner in all three areas of the criteria. So it is my pleasure to announce that the winner of this year's award for lifetime service to the field of health policy and systems research is Professor Lucy Gilson. So I get to say a few words to embarrass her as best I can. Lucy, as many of you know, is the professor and head of the Health Policy and Systems Division at the School of Public Health and Family Medicine at University of Cape Town, and if that weren't enough, is also professor in Health Policy and Systems in the Department of Global Health and Development at the London School of Hygiene and Tropical Medicine. And she has, as I will describe shortly, been leading the way in promoting research and health policy analysis, in educating and mentoring junior colleagues and scholars in the field, as well as being working on the field with improving health systems. So as you will see, she really is a Triple Crown winner in this area. So I'm going to read from some of the nominations letters that describe her. So Lucy draws on multiple theories and frameworks from the social sciences to make seminal contributions in numerous areas of concern central to health policy analysis. These include important research in areas of power in health policy processes, of which we just heard about, policy implementation and the role of street-level bureaucrats, which we also just heard about, trust, health systems resilience, every day, accountability, equity, health worker motivation, sector-wide approaches, and donor involvement in health, as well as developing and exploring theories and methodological approaches in health policy analysis. She has focused her work on the building of the field also through collaborative practice with people working in the health system. Her partners in the City of Cape Town Health Department and the Provincial Department of Health, both note that she has had long-term commitments to their partnerships, and they have jointly produced and learning in action that has been of daily relevance to improving policy implementation in health services delivery. Another example of her works includes work she has done with support from the Alliance for Health Policy and Systems Research to link researchers from Asia, Africa, Europe, and North America, bringing together doctoral students from low-income countries that are working on health policy analysis dissertations, along with their advisors, and they work together to jointly strengthen their dissertations. And really, as you can imagine, this type of work is emblematic of her approach to bring people together. She brings it with enthusiasm and provision of opportunities and forging new networks among health policy scholars. And this is all towards this overall purpose of advancing health equity. So we talked about values of the society, and I just have to say that all of the work that Lucy has done is linked by this deep concern as well as sophisticated analysis and attention to how power manifests itself in health policy processes and in systems at the ground level, and again with this focus of attention to equity, accountability, and their effects on the lives of disadvantaged populations. So it's my great pleasure to have you award for lifetime service to health policy and systems research.
Thank you so much to the Alliance and to Health Systems Global. I am truly honored by this award. When I was 26, I became a reluctant academic. I just finished working in Swaziland, Eswatini in the Ministry of Health, and I was going on to what I thought would be a practical career in health and development. But at that time, I was offered a job in the London School of Hygiene and Tropical Medicine to work with Anne Mills, and I was welcomed into the school also by Jill Walt. And these two inspiring mentors showed me that academia is a practical place, that the ivory tower should have no walls, that we should be open to and influenced by the world around us. Since then, I've come to understand the power of ideas that shape our actions and in that way take on a life of their own. I've also come to understand the critical place or the critical role of universities in education, in sharing ideas and in developing the people who will use those ideas for social action. Health policy and systems research is an incredibly important field for social action. Health systems are a place of deepening social solidarity. I believe that the work we do in this society is inherently political because we are, notwithstanding the reversals, day by day, on a step-by-step basis, moving towards social justice. And in doing that, to maintain momentum, we must work collaboratively. And I have had the privilege of working with many collaboratives over my years, and I'd like particularly to thank 4 of them. Firstly, Equinet, an activist organization that for more than 20 years has put equity and health on the agenda in Africa and has brought it alive in practice. Secondly, thanks to CHEPSA, a consortium of African and European universities whose teaching materials continue to spread the core ideas of HPSR. Thirdly, to my colleagues and friends in the CRESS and RESIST research program consortia. For over 10 years, we've researched and laughed together, and we've seen the emergence of leaders in this field, today's leaders, tomorrow's leaders, who are making a difference in the health systems in which they work. Our experience shows that strengthening health systems and the people that will strengthen health systems just does take time. There are no magic bullets. It's a valuable investment. And finally, I want to thank my colleagues in the Chesai Collaborative based in Cape Town, a collaborative of health managers, policymakers, researchers, and educators. It is an incredible privilege to work with you. And whether you're here in Liverpool or at home in Cape Town, I thank you so much for the opportunity to continue to learn with you. Enkosi, Nyabonga Gakulu, Asanteni.
I'm so glad so many of you stayed behind because this is really a highlight. There are many highlights in the symposium, but I'm really pleased that we have the space to recognize those who are really founding thinkers and leaders by example. I have the pleasure to announce the award for the Sama J. Distinguished Public Service Award, which is for individuals that are currently in positions of government, in an international agency, or in a civil society organization. And from those positions, individuals that champion health policy and systems research and its application in policies and programs. In this occasion, we had many very strong nominations, which is fantastic for the field, but makes the decision quite hard. But the individual for which we are providing this award is just exemplary in so many ways. We're very pleased to announce that we're giving the award to Dr. Viroj Tangcharoshapien. Please, could you come forward? For many of you are very familiar with both Lucy and Dr. Viroj, but let me say a few words nonetheless. He's currently Secretary General of the International Health Policy Program Foundation in Thailand, and he has contributed to strengthening health systems in Thailand since the 1980s. He started his career as a medical doctor in rural health hospitals in eastern Thailand, for which he was recognized as the best rural doctor by the Thai Medical Association in the 1980s. And from that very grounded experience, he then moved into very senior positions in the Ministry of Health, advising at the highest levels on health policy and planning. Since the 1980s, he's really been championing health policy and systems research as a key foundation for supporting and sustaining progressive universal health coverage in Thailand. And the Thai UHC story is very well documented, but our awardee tonight is really anchored so much of the evidence behind it. He's led so many countless studies and analysis that really informed the architecture of the health reforms behind it. I'm going to give two examples that are quite detailed but show the level of expertise that he brings, moving from clinical practice to really engaging with these health reforms. For example, he estimated the costs of the benefits package and updated it over time as a key measure to advocating for increased funding to really enable these reforms to have effect. He also ensured there were annual surveys undertaken to actually measure whether they were having impact, whether there was a reduction in health expenditure and increase in health utilization. And those annual surveys are now mainstreamed by the Central Statistics Office and are part of the way of doing business in Thailand. He's been the driving force of the creation of the International Health Policy Program and has really ensured its quality as a think tank, as a policy-informed research entity within the Ministry of Public Health, but also slightly as a distinct entity within that. Apart from the hundreds of articles he's co-authored and led, he's also ensured the mentoring of many Thai health policy and systems researchers in the country, as well as ensured fellowships at the program, ensuring there's a very strong pipeline of health policy and systems researchers that are engaged in policy in Thailand for years to come. Given his expertise, he's very well known in the region and highly sought out all over the world in terms of advising universal health care. He's worked with building the capacity of member states in engaging in global debates at the World Health Forum. So apart from impacting Thailand, he's really worked at empowering other countries and giving them voice in global fora in that way. He's been behind a number of regional collective one voice statements. And for me, although he's known for his role in supporting UHC in Thailand, he's always on the cutting edge also. So authoring articles on multi-sectoral action, speaking out about intersectionality. This is someone who's really on the forefront of health policy and systems research and has his finger on how do we engage with government and other actors to make sure it translates into practice. So for those reasons, we very much like Dr. Samajay, we're giving this award to Dr. Viroj because he combines an engagement in health policy, systems research and development, in playing a leading role in the relationships and architecture that makes sure that research is done at high quality, but research has impact in policy and programs in its application, and thereby really affecting the trajectory of what's happened in Thailand and in many other places. Please join me in acknowledging their accomplishments.
Friends and colleagues, sisters, brothers, it is a great honor to be one of the two awards. My fellow awardee, Lucy, I'd like to give a few remarks. As UN member state, we have committed to many UN General Assembly resolutions. Our government, our head of state has committed to many high-level, UN high-level declarations. And we have promised to deliver SDG, at least 3 point, SDG 3 by 2030. Having reviewed a number of literatures, we found that we are under a syndrome called resolution and declaration fatigue syndrome. Because government did not deliver and most of them deliver the empty promise. What happened? The challenge of SDG is much higher than the MDG. Give, for example, ending TB, ending HIV/AIDS. We all know how complex health system complexity to deliver the effective coverage of ART, how we have a primary prevention of HIV. This all promised by 2030. Give an example of road traffic accident, road safety. This year in April, we just adopted UN General Assembly resolution on road safety. All this must be done by 2030. Give, for example, tobacco and alcohol. Despite the fact of FCTC, last week in the COP, the Conference of Parties of FCTC meeting in Geneva, there's a fight back by tobacco industry. And even tobacco industry has sponsored some country delegation to the COPs. This is according to published evidence from the NGO. So that means government is weak in terms of three points. Political and financial commitment. This is reflected by the high level of out-of-pocket payment and impoverishment and catastrophic health expenditures. While the government is weak, the industry becomes stronger. We always see and hear the story of regulatory capture. That means this day we see rat is bigger than cats. The regulators are tame and young cats who cannot catch the rat. And sometimes the rat will bite in the cats and transform the cats to be the rat. So that means the regulator become captured by the regulatee. And we all see at home our cat cannot catch mice because they are not trained to catch mice because they eat tablet, cat feed. It's true. And this happened to our country as well and many others. The implementation capacity gaps. Apart from financial and political commitment gaps, there is a big implementation capacity gaps, which is a no-do gap. There's plenty of evidence in DCP2, DCP3, in many Cochrane collaboration synthesis, as well as many research consortium generate evidence. But how we scale up the implementation capacity, it is a big challenge. The third gap is the impact assessment or M&E gap, which hold government and other stakeholders accountable. This is one of the big gaps that we have to address. Now, these are the contexts ahead of us 12 years before we end 2030 of SDG commitment. What should HSG, Health System Global, contribute to? I'm thinking of not only improve HPSR capacities in generating evidence, we need to improve the retention of these capacities. We need to embed research capacity in the implementation arms. That's what always Dr. Abdul Ghaffar, the HPSR Alliance, always advocate, embedding research in the implementation arm so that people in the implementation agency can scale up their implementations. And finally, we have to improve the M&E part research to assess whether the stakeholder is accountable and doing their job as promised or not. In the past 10 years, since the first meeting in Montreux, and followed by Beijing, Cape Town, Vancouver, and then come to Liverpool, I see a huge capacity development. But this capacity is inadequate to meet the complexity of challenge of SDG commitment. We need to build up 10 times more. That by 2030, we see 10,000 or 20,000 of HPSR capacity HPSR researchers who are very capable. So this is possible. At the same time, one of the missing links is public health law. Tobacco and alcohol industry put a lawsuit to Australian government on plain packaging, put a lawsuit on Thai government on increase the size of tobacco package warning from 65 to 85% of the front and back side of package. And we won. They have money power to hire an international law firm. This is one of the weakest links that HPSR committee may expand their capacity to have more capacities to work with NGO, with lawyers to fight back. Because while we scale up the government capacity, we need to scale up and fight back the industry who fight against and put all the political interference of the public health law. When we passed a law last year on the code of translate the code of marketing of breast milk substitute into national legislation, we witnessed a fight back by BMS breast milk substitute industry, and the high professor pediatrician to fight back and saying that in Nepal, stunting increased because of mother continue to breastfeed beyond 12 months, which is true. We look at the papers, but it is stunting is a complex determinant of poverty, food insecurity, and maternal education, not only the mother who breastfeed beyond 12 months. So we published papers to fight back this misled information by the industry. Finally, I must thank my teacher, Professor Ann Mills, who groomed me and mentoring me, Kara Hansen, Lucy Gilson from London School, and we have been working together since 1993 in build up capacity of our young research fellows to be trained in a world-class academic institution and come back and serve the country, not only Thailand, but for the whole region. Thank you. I must pay tribute to Sam SJ, who I know best. We worked together since the early 2000s when I was chairing Gavi Independent Review Committee, and he is the able committee member from Ghana. Thank you very much.
So thank you so much. These are very humble individuals, and I'm so pleased that we could acknowledge their contributions to health policy and systems research and practice. We're going to close this session. It's an exciting morning plenary on community health systems, and we have many more sessions ahead. But I really look forward to your engaging with everyone around you and building this community that is so important for health policy and systems research. Thank you very much.